Welcome back to AAKP's National Kidney Patient Consumer Policy Roundtable, the critical need to overcome government determinants of health. We're now moving on to our second panel in our two-part discussion entitled Opportunities and Challenges for Stakeholders, Federal Policy Implementation Interpretations Impacting Kidney Patients and Medical Innovation. The second panel deals with the alignment or misalignment between medical innovation and reimbursement, and how those decisions can impact patient care choice and access to new products. I would like to introduce Dr. Laura Williams, Chief Medical Officer of Ardelyx. Dr. Williams is a strong patient advocate with a deep sense of urgency to target the right therapy to the right patient at the right time. And Dr. Williams, please tell us a little bit about Ardelyx and the company's commitment to bringing timely innovations to a disease field that is too often overlooked.
Yeah, thank you. Thank you for that question, and thank you for allowing me to attend the panel today. Ardelyx is a small biotech company that is based in Waltham, Massachusetts, so in the greater Boston area. And our mission really has always been to discover, develop, and commercialize really innovative products to address unmet medical need. And one of those products, as it relates to chronic kidney disease, is a new compound used to treat a condition that dialysis patients often face called hyperphosphatemia. So there are a number of different sort of laboratory abnormalities that happen once the kidneys fail. We know about anemia, right? Because they can no longer produce a hormone that allows the red blood cells to be made, and so anemia. Another one is hyperphosphatemia, because normally with good kidneys, right, with normal functioning kidneys, it excretes most of the phosphorus that we take into our diet. And so when the kidneys fail, the phosphorus levels build up, and you can't get rid of it. And so when you think about all of the different laboratory abnormalities, hyperphosphatemia carries the highest risk. 6 times higher risk of mortality than, for example, PTH, which is another issue that dialysis patients have, a 3-time higher risk than hypercalcemia when their calcium levels go up, and a 2-time higher risk than the anemia that I talked about. And so for that reason, we have guidelines that tell us that we need to lower serum phosphorus toward the normal range. And so when you look at how you do that, for the most part, there are a couple of non-pharmacological approaches. One is you could just say, well, decrease the amount of phosphorus that you take in your diet. But that's a little bit difficult, right? When you think about the fact that phosphorus is ubiquitous. It's in all the foods that we eat. It's higher in processed foods, but it's also present in good food like fish and nuts and eggs, and so things like that. The second approach you could say is, well, you can increase the frequency and the duration of dialysis, but that's a little impractical. These patients are already having 3 dialysis sessions a week, 3 to 4 hours at a time. And neither the patient nor the dialysis facilities can actually afford much more than that. So those are sort of impractical approaches. So when you then move to the pharmacological approaches, really for the last 5 decades, we've only had one mechanism of action in terms of drugs, and it's phosphate binders. And as the name implies, you take them by mouth, and they bind the phosphorus that you've taken in through your diet. And it was only until recently that we, Ardelyx, developed a new drug. It's a phosphate absorption inhibitor. So instead of binding, it blocks phosphorus. And so it's an innovative approach for a long-standing problem. Because one of the things you have to understand is that while the guidelines tell us that we need to lower serum phosphorus towards normal, and while 80% of dialysis patients have been taking phosphate binders, most of them are not at goal. So they've not been able to get to target goals. And when you think about other treatment or other therapeutic areas, Dr. Quagan mentioned some of the things that you could do to prevent the progression. You think about sort of diabetes, the number one reason that patients actually end up with, end-stage kidney disease. Well, when you look at all of those different areas, we never address those with one mechanism of action. I mean, you think about diabetes, we got metformin, we got the SGLT2 inhibitors that she spoke about. You have Ozempic, so you got the GLP-1 agonist. You've got a multitude of drugs with different mechanisms of action to help you get to your target goal. Why do we expect, or why do we provide less for dialysis patients? Why do we just want one type of drug? They should have the same level of innovation that all of our patients have. We have never, when you look at any therapeutic area, whether it's cardiovascular, whether it's renal, whether it's infectious disease, HIV, we have combination therapies. We have therapies with various mechanisms of action. And so our goal at Ardelyx is to bring forth innovative medicines that actually help with this significant problem that carries a huge morbidity and mortality.
Thank you. Can you tell us a little bit about the challenges that your company is having in bringing forward this drug and the reimbursement challenges and clearing some barriers that to patient access?
Yeah, absolutely. I mean, we obviously, the road to actually getting the drug approved was somewhat arduous, right? Despite all of our clinical trials having met their primary efficacy endpoint, and despite there being no safety concerns, we had to go through a long and arduous, sort of process to eventually get the drug approved. But it was approved in October of last year, October 2023. And it's great to get a drug approved, right? But it's more important to make sure that patients have access to that drug. And so when you think about, you've already heard a little bit about, the ESRD, prospective payment system, otherwise known as the bundle. And so all of the drugs, so what does that do? So basically, there used to be a fixed payment system, right? So Medicare, CMS paid for everything for patients who were on maintenance dialysis, starting in 1972. And in 2011, this was mostly driven by the use of drugs to treat anemia, like EPO, where there was a lot of use of that and big doses, right? And so it was driving up costs. So in 2011, CMS put together the bundle system to basically lower the cost. And what that does is basically it provides a fixed payment for every patient every time they sit in the dialysis chair. And what does that pay for? It pays for their dialysis treatment, it pays for any medications that are given during dialysis, and it pays for the equipment that's used. It pays for the staff that are actually taking care of those patients during the dialysis service. And so what happens is all of the drugs that are given in dialysis, the anemia drugs, the drugs for, bone disease that happens with end-stage kidney disease. So anemia drugs, calcimimetics, all of those drugs are in the bundle. And what we've seen over time is that every time there's a more innovative drug, there's not really an incentive to use the newer innovative drug because you have a fixed payment. And so that fixed payment doesn't often cover the expenses of the new drug. And so now, with the phosphate-lowering therapies, these are truly oral-only therapies. Typically, the other drugs that are included in the bundle have both an oral and an injectable equivalent, right? So that they are actually given during the dialysis service. But phosphate-lowering therapies truly are oral only. There's not an injectable equivalent because remember, the drug has to get in the gut where the phosphorus is. So it's only oral, and it can't be given during dialysis, whether it's a phosphate binder or our drug, a phosphate blocker. And why is that? Because you have to take these drugs with food, and you can't eat during the dialysis session. So it's unprecedented to actually even think about including these drugs in the bundle system. And so for 3 times in the past, Congress has acted to say, you're right, these drugs shouldn't be put into that bundle system. But guess what? That expires on January 1st, 2025. And so unless Congress passes another law to say, we shouldn't put these drugs in there, because for a number of reasons, and I can go through some of them. One, it takes away the physician-patient shared decision-making. 2, it diminishes the choice, because the more innovative drug usually costs more and is less likely to be used in that fixed, in that fixed bundle system. And so unless Congress acts again to, prohibit the inclusion of these phosphate-lowering therapies in the bundle, they will go there. And so we've been working a lot on the Hill, trying to make sure that something happens to prevent this, because we think that would actually be detrimental to patients. And so there is a new bill that was introduced in August of last year called the Kidney Patient Act. It's H.R. 5074. It was introduced by Representative Buddy Carter with co-sponsors Miller, Custer, and Sewell. And since then, a number of other Congress women and men have signed on to it. And so there's really actually no one that opposes this. The dialysis providers don't want these drugs to be in the bundle. This bill that I just talked about is bicameral, bipartisan. And then we've got a number of, external vendors or supporters of this bill. I shouldn't say vendors, but advocacy groups. AAKP being one of them. AKF, NKF, NAACP, New York, Hill Collaborative, NMQF, the National Minority Equality Forum. There's a host of folks that understand that what would happen if this bill isn't passed is that it would likely widen the disparities that already exist. We heard that there's 37 million people impacted with chronic kidney disease, about 800,000 with end-stage kidney failure. And guess what? It's a 4-fold higher rate in blacks and a 2.5-fold higher rate in Hispanics. And so those disparities just worsen when you limit choice and when you take away that shared decision-making that patients should have with their caregiver.
That ties perfectly into my final question for you, which was, can you give us your perspective on how the federal reimbursement decisions contradict national efforts to address unequal care access and disparate health outcomes? Yeah,
I think, obviously, again, when CMS enacted this concept of the bundle system, the PPS, it was with good intent. It really was. And I think there are examples of where it worked, and anemia is one of those. But guess what? In the anemia example, in addition to the cost saving, what we had is good data. We had data that said we shouldn't be raising hemoglobin levels higher than X, and we shouldn't be using these huge doses. So you had actual science that, really helped inform that decision. It was the right thing to do. But as you look further now and you look at some of the other agents that have been added, what we've seen is a decrease in use of the more innovative drugs, even when there's data to suggest that those drugs might provide more benefit to patients. And so my worry and my concern is that patients are the ones that are going to suffer even more because of this. And so I think there are now unintended consequences of, just throwing everything in the bundle. Imagine if they were to then throw in all of the drugs that we use for diabetes or hypertension. It would be an enormous mistake. And so I think we have to avoid those unintended consequences. And again, Congress has acted 3 times in the past to say this is not good for patients. And I think we have to do everything we can to support the bill that's been put forward to make sure that it doesn't happen now.
Great, thank you. I'm going to turn it over now to my good friend Paul Conway. Welcome back, Paul. For these types of issues, can you lay out for our listeners the types of education and advocacy efforts AAKP will be engaged in to increase patient awareness of the new innovations and also to show listeners how to take action?
Sure, Ed. So if folks take a look at our agenda there in the links that we've provided, they have a sense of some of the background information about these types of issues, in particular, and the complications that are raised, not when we're advocating for a new product to be approved, but how it gets paid. And in the case of CorMedix and what Chris Boland has raised, what Dr. Williams has raised, what's very important is that patients channel their voice, and they can do that with AAKP through congressional letters, through visits with their congressional leaders, and most importantly, to be available when we are asked as AAKP to staff by the agency technical evaluation panels on quality of treatment, feedback roundtables from federal agencies to communicate what the patient burden is. Because a lot of times, as Dr. Williams has pointed out, you have payment decisions that are being made based on what a program is supposed to do as opposed to what's good for people. And if people don't raise their voice, then you can expect people who administer programs to simply administer the programs. But unless we elevate that patient voice into the middle of that, oftentimes we do get the unintended consequences, or as what you outlined this morning, Ed, government determinants of health that have negative consequences for patients. So bottom line, join AAKP, you'll learn about these opportunities, and you'll have a powerful platform to add your voice to other patients to make certain that payment aligns with the new innovations that are out there and care gets to the people who need it. Thanks.
Thank you, Paul, and thank you to our panelists for joining this important discussion. AAKP believes that in many instances, CMS has lost sight of unmet patient needs and instead approached payment decisions with a one-size-fits-all approach that lacks expert stakeholder input. I encourage our audience to visit AAKP's Action Center at bit.ly/AAKPT. Take action regularly. Add your voice to the thousands who are contacting their elected representatives on issues related to this last panel discussion.